We've learned quite a bit about the cardiovascular system in the first three parts of Chapter 19. We've learned about blood flow and blood pressure, the regulation of blood pressure in the short term, in the longer term by controlling blood volume, hypertension, hypotension. Let's just wrap up this chapter with a couple of very important and interesting topics that some of which are kind of along the same lines we've been talking, but some of them are actually quite different and interesting. Autoregulation. Each tissue determines its own blood flow, and it does so according to the metabolic activity in that tissue or organ. So local control of each organ determines the blood flow through that organ, and the sum of all those blood flows determines venous return, and therefore stroke volume and cardiac output. So cardiac output really is defined by or determined by the sum of all the demands of each individual organ in your body. Pretty cool. So flow, we learned earlier, is driven by a difference in pressure. Mean arterial pressure drives flow, and it's opposed by resistance, the narrowness of the opening of the arterioles. Well, we can think, we've been thinking about that in terms of the entire system. Flow is cardiac output. And now we're going to just talk about flow locally. What's the flow in a kidney, for example? Well, if the flow in a particular organ is too low, the arterioles in that organ are going to vasodilate. And if you vasodilate, you reduce resistance. And this number in the denominator gets smaller. Therefore, when you divide, flow gets larger. So vasodilation increases flow in that organ. If the metabolism in the organ slows down and it doesn't need as much blood flow, arterioles will vasoconstrict and reduce the flow. So how does that work? Well, the main mechanism is called metabolic autoregulation, or active hyperemia. Hyperemia just means extra blood flow. Let's see what's going to happen. If blood flow is too low for the metabolic activity of a tissue, CO2 produced metabolic is going to accumulate. Oxygen is going to start to decline as the cells are using up the oxygen. Some lactic acid will be produced, some hydrogen ions will build up. They also are produced from CO2. So oxygen's down, CO2's up, hydrogen ions are up. That causes the vascular smooth muscle cells to dilate. That's just how they respond. These local conditions cause the relaxation of the muscle cells. No neurons have to come in and talk to them or anything else. They just dilate in those conditions, and when they dilate, more blood flows to the organ and corrects all these problems. Takes away the CO2, brings in more oxygen, takes away the hydrogen ions, and so forth. So that's how it works. What if the flow is higher than necessary? What if an organ, let's say a working muscle, stops exercising and the metabolic rate drops? Now we got too much blood flowing through there. Oxygen's going to be way up high, CO2 is going to be way low. We're washing away CO2 as fast as it can be produced. Well, when CO2 goes down and oxygen goes up, vascular smooth muscles, cells, and arterioles constrict. So if there's too much flow, they constrict. If there's too little flow, they dilate. And they just do it in response to the local chemical conditions in the tissue. Pretty cool. So that's how each organ can keep on adjusting its flow to exactly match its metabolic activity. Well, if all the arterioles in a tissue are vasodilating, there might not be enough blood flow through the larger vessels supplying that organ to really give the extra flow that's being demanded. And so another thing that happens is endothelial cells, the lining cells of the blood vessels, start releasing nitric oxide when things get hypoxic. And nitric oxide is a major league vasodilator, and it'll open up the bigger pipes, and we'll really be able to get the blood into that tissue, into that organ. So that's called active hyperemia. What about reactive hyperemia? Think of what happens when you go outside in the cold and you get your hands really, really cold. Let's say you throw about 50 snowballs and you didn't even have your gloves with you. A spontaneous snowball fight broke out and your hands are really cold. Well, what's been happening is they've been vasoconstricted very aggressively to prevent more and more heat loss from your digits, and so there's not enough blood flow. When there's not enough blood flow, all the metabolic waste products such as CO2 and hydrogen ions are building up in the tissues, And then when you finally go inside and get warmed up, there's a ton of vasodilation happening because there's, again, all those conditions that make smooth muscle cells relax are present, and you get this massive return of blood flow to the digits, to your extremity in this case. That's called reactive hyperemia because all those wastes have been building up during vasoconstriction, and now you're going to have a massive increase in blood flow. You'll see your fingers turn bright red. They may even be painful, bringing all that blood flow into there immediately like that, and then eventually things will get back to normal. All right, there's another component to autoregulation. It's called myogenic autoregulation. Here's the deal. Let's say you grab some vascular smooth muscle and tugged on it. It would react by contracting. If you pull on or stretch smooth muscle in the blood vessels, they'll constrict. So what's the upshot of that? If blood pressure goes up, mean arterial pressure goes up, that's going to force more blood into all the arterioles and stretch them out. And what will they do in response? They'll constrict a bit. Now, if mean arterial pressure goes up and nothing else changes, that means a lot more blood is going to be flowing through all the organs. But that is dampened out a bit because what happens is the arterioles, in response to the stretching, contract, and blood flow does go up, but not quite as much. Or, if blood pressure goes down, the smooth muscle cells are not being stretched as much, and they dilate. So if blood pressure goes down, blood flow to all the organs would go down, but it doesn't go down as much as all the arterioles in the organs dilate a little bit to bring in some extra blood flow. So what happens is that myogenic autoregulation kind of dampens out changes in blood flow in the organs as changes in mean arterial pressure occur. Keep the flow more constant. We really only need to send the amount of blood to tissues that match their metabolic needs, and we don't want to send less blood than what they need. There's one last aspect we should mention about autoregulation, if you can call it that, angiogenesis. If there's a long-term hypoxic condition in some tissues, the endothelial cells in the blood vessels and other cells that are hypoxic in the region will release vascular endothelial growth factor. So VEGF is a growth factor which will stimulate blood vessels, new capillaries in blood vessels will sprout from existing blood vessels and start filling in the area to provide increased blood flow. So that's the coolest thing ever, right? If every time you injure your tissues, you damage some blood vessels, all of a sudden there's no flow to that area. Angiogenesis occurs. We talked about that way back when. Wound healing, and we use skin as an example, or the dermis of the skin. So new blood vessels will grow right in there to supply the oxygen that the tissues need. So that's the gist of autoregulation. There's a few special cases we should talk about. So remember, metabolic autoregulation is the main mechanism. Myogenic autoregulation kind of dampens out changes in flow with changes in blood pressure. How about in the heart and the brain? There's this extra tight control of blood flow by autoregulation in the heart and the brain. These organs are so critical for the function of our entire body that they must exactly match the blood flow at all times to their metabolism. If you start exercising and the heart does more work, it needs to get exactly the additional blood flow to supply all the oxygen and fuels that it needs. Brain, same thing. The central nervous system requires oxygen, and no matter what else is happening in the body, the brain must receive the right amount of blood flow, and so there's tight autoregulation, metabolic autoregulation. The sympathetic nervous system does not interfere with this process. Now, we'll talk more about the sympathetic system interfering or overriding metabolic autoregulation in a bit, but not in the brain and heart. Okay, how about the lungs? Metabolic autoregulation is reversed in the lungs. When there's increased oxygen and decreased CO2, that instead of what happens in the other tissues, it causes vasodilation. It's because the lungs have a different function. They need to supply oxygen to everybody else. So if there's a lot of oxygen in some part of the lung, that means there's good air, fresh air getting to that part of the lung. We say the lung is well ventilated in that area. Fresh air coming in. So we want to move blood towards that area so that it can become oxygenated. So wherever there's good ventilation, we want to send the blood there. We do that by dilating the vessels in that area. Or if there's part of the lung that's not getting good ventilation, right? The lung is not 100% homogeneous in terms of how much fresh air is getting to all the little air sacs. If there's an area of the lung that's not as well ventilated, we don't want to send blood there because there's not oxygen available, so we'll constrict that area and divert the blood to the parts of the lung that have really good ventilation happening. Skeletal muscles. Skeletal muscles do vasoconstrict somewhat when there's sympathetic activation, as long as they're not the exercising muscles. Exercising muscles control their flow by autoregulation. But the reason they can kind of get away with that is the sympathetic nervous system doesn't constrict them so much for two reasons. Two reasons why there's less sympathetic constriction in skeletal muscles. One, there are sympathetic cholinergic neurons, meaning neurons that release acetylcholine, which tends to cause vasodilation in opposition to the alpha-1 receptors. And I guess I said these in the opposite order. Also, the smooth muscle cells in skeletal muscle blood vessels have beta adrenergic receptors as well as alpha-1 receptors. So when the norepinephrine comes along, and the epinephrine comes along, instead of just causing vasoconstriction, there's this sort of conflicting response which really kind of cancels out, and there's not so much vasoconstriction, and metabolic autoregulation can be the control of blood flow entirely. Skin circulation. Skin circulation is under the control of the hypothalamus when you need to do body temperature regulation. When you start exercising, sympathetic nervous system will cause constriction of skin arterioles. But when your body temperature starts to rise, the hypothalamus will dilate those vessels in the skin to divert a lot of extra blood flow to the dermis so that we can bring that hot blood to the surface and get the evaporative heat loss going and cool the body so the body temperature doesn't rise too much. So skin circulation has that dual function. Nutrition for the tissues involved, but also temperature regulation. So all this about autoregulation, well, the sympathetic nervous system, when you exercise, can sort of interfere or take over control of blood flow in some organs. It causes vasoconstriction in the abdominal organs, your small intestine, large intestine, your stomach. All those organs are going to get vasoconstricted. We're going to take away some blood flow. If constriction happens, flow goes down. Skin, same thing until you start getting hot. Kidneys, same thing. We're going to vasoconstrict and divert all the extra blood flow over to the working muscles so that they can have plenty of blood flow as they do autoregulate. And here's a cool little diagram showing some of the changes we're talking about. Skeletal muscles. The amount of blood flow in the skeletal muscles is represented by this red bar graph that looks kind of like a blood vessel. So let's say before exercising, 1.2 liters per minute we're going to all the muscles. Now during exercise, this fellow is starting to get into it a little bit. All of a sudden, 12.5 liters per minute and going to all those exercising muscles. Well, where's all that extra blood coming from? Well, it's coming from the cardiac reserve. We said that the cardiac output will jump up from, say, 5 liters per minute to 35 liters per minute, but also going to divert blood from other organs to the muscles. Let's take a look. Kidneys were getting 1.1 liters per minute. Now they're only getting 600 mils. The abdominal organs were getting 1,400 mils per minute. Now they're only getting 600. So big drops in the flow to those organs. All that extra blood flow is going to go to the muscles. Now the heart is going to auto-regulate exclusively, so it will get the extra blood flow it needs to work harder to pump that extra cardiac output during exercise. The central nervous system still needs all of its blood flow. So the sympathetic nervous system diverts blood from organs that can spare it for a time being in order to maximize flow to the muscles in the heart and the brain. So that's just repeating what's on the slide, is repeating those notions. Sympathetic nervous system during exercise vasoconstricts arterioles in the kidneys, GI tract, and the skin, and reducing their flow, and then autoregulation in the skeletal muscles will bring in all that extra flow there to give the oxygen and nutrients for the muscles. Here's just a simple concept I just like to quickly mention. It's a one-slide deal. If you look at the total cross-sectional area We add together the cross-section, the area across every cylindrical blood vessel in different parts of the vascular system, and add them all up and see what the sum will be. Let's take a look and see what we get. Let's say we look in the arteries, the big arteries, and add up all of their cross-sectional areas. It's a low number. They're wide open pipes, and there's only a few of them. And so we can push a lot of blood flow because they're very large in diameter, but the sum of the cross-sectional areas is actually low, and the blood's going to move through there at high velocity. Here's the velocity of blood flow. High in the arteries. There's not as much cross-sectional area. We still got to get the same, right? 5 liters per minute here, 5 liters per minute here, 5 liters per minute here at rest. If there's a smaller diameter, you have to push the blood through at higher velocity. We come to the capillaries. They have a very, very large cross-sectional area. There's so many capillaries that there's a much greater sum of the cross-sectional areas of all those capillaries. Consequently, the flow is much slower in the capillaries. How convenient, because we need some time for oxygen and nutrients to diffuse across those capillary walls. Well, we have the time now because the flow is way slower in the capillaries. And then we get into the veins, we let the flow go back up to a much higher rate because we're not worried about diffusion there. It's just a cool thing. Smaller cross-sectional area in arteries and veins and high flow rate. High cross-sectional area in the capillaries and low flow rate, so there's time for diffusion. This slide we don't need to spend a lot of time on right now, but you can check it out. It's just summarizing everything we said, anything that can cause vasodilation or vasoconstriction. Those things that control blood pressure in the short term. So look through this list and see what you make of it. It should be everything we already talked about when we talked about short-term control of blood pressure. Now we come to the subject of capillary filtration. Capillary filtration means water and small solutes being forced through the wall of blood capillaries under pressure. Right? So all of the capillaries have some kind of little pores in them, fenestrations, pores through which water can be forced under pressure. So when the blood enters the capillaries, there's some pressure there and it pushes water out. So out of all your capillaries, there's leakiness happening. Right? Here's a closer up picture of a capillary with some pores in it where water can sneak through like a screen, essentially. The proteins can't get through. Right? Those are big and bulky molecules, but the salts and the sugars and things and the amino acids in the water can sneak through. That's called filtration. It's not diffusion. It's pushing water and small solutes right through by what's called bulk flow. So we don't need to spend too much time here. I just want you to understand that if you put some pressure inside here, water is going to escape through this wall by what's called bulk flow. There are vesicles that carry some water across endothelial cells. That's a subject of some debate and discussion, but it's not really a physiologically important thing for us. Okay, let me introduce you to a really cool concept about this capillary filtration and capillary function. Here's the artery, or arteriole. There's a pretty high pressure in there. And as the blood enters this capillary bed, there's a fairly high pressure, somewhere in the order of 35 millimeters of mercury pressure of blood. And that extra high pressure forces water out of the capillary walls. Those little black arrows represent water oozing out of all those capillaries. But as we transit through the capillaries, the blood pressure starts to fall. And it might be as low as only 17 millimeters at the other end of the capillaries. And interestingly, the water will start going back into the capillaries. It'll be drawn inward. We have to discover the forces that are responsible for that. So water goes out in the arterial end, mixes with all this interstitial fluid and brings lots of good nutrients out to there, and then a lot of the water goes right back in and then into the veins and back to the heart. Well, a little bit of water is lost during that process. So we need a way to recover that water, and the recovery mechanism is called the lymphatic system. A whole extra vascular system of one-way vessels that collects all the water that escapes from your capillary beds and slowly returns it back to the veins. So we need to think about osmosis to understand what we're about to talk about next. What are the forces that govern capillary filtration? Well, let's take a look at this U-tube here. It's a U-tube, a glass tube filled with water, and there's a little boundary right here that will block the movement of solutes across it. So these purple balls represent solute molecules. They cannot cross this semi-permeable membrane, which represents the endothelium of the capillary wall. And we've got equal amounts of water, but not equal amounts of solute. We've got more solute on one side, which is the capillary, and we've got less solute on the other side, which might be, say, the interstitial fluid. And if we let this sit like this for a moment, water will move from us by osmosis across the semi-permeable membrane. Right? There's higher water concentration on the right side than the left side. Water's going to cross over by osmosis. You can think of it this way. The solute molecules have pulled the water by osmosis. That's called osmotic pressure. The ability of those solute molecules to pull water across that semi-permeable membrane is called osmotic pressure. And that's exactly what the conditions are like in a blood capillary. If you look inside the capillary, there's a lot more protein concentration than in the interstitial fluid. That represents an osmotic pressure difference. Right? If there's protein here in the interstitial fluid, that would have an osmotic pressure pulling towards the interstitial fluid. If we had protein in the capillary, it would represent an osmotic pressure pulling water towards the capillary. Well, because there's more pressure inside, it's a larger force. So if we subtract the osmotic pressure of the proteins out here from the larger osmotic force of the proteins inside the capillary, we have a net inward force. That's just the osmotic forces, the solutes, the proteins. How about hydrostatic pressure? That means just blood pressure. The blood pressure inside the capillary. Well, there's really no pressure out here in the interstitial space. So we have some pressure in the capillary, which is a force pushing water outward, and it will force water out through some kind of pores in the wall. And so that's an outward force. We have osmotic pressure, which is an inward force. And you subtract the two of those forces in opposite directions, and when you get what's called net filtration pressure. That's the overall force acting on this capillary wall, and it's pushing water out. Now this is at the arterial end of the capillary. We have this positive net filtration pressure forcing water out of the capillary because we have a lot of blood pressure in here, 35 millimeters of mercury. Now let's go to the venous end of the capillary. The hydrostatic pressure, or blood pressure, has dropped. So now it's only 17 millimeters of mercury. The oncotic pressure or osmotic pressure difference is still 26 millimeters of mercury. Now it's the larger force. So the inward osmotic pressure difference is greater than the outward hydrostatic pressure. What's the balance? When we subtract 17 from 26, we have what's called a negative net filtration pressure. Water actually moves into the capillary at the venous end. Isn't that cool? So we have osmotic pressure pulling water in, hydrostatic pressure pushing water out, and whichever one is the bigger force will win, and water will move in that direction. Just to remind you, over the course of that entire capillary, though, there's going to be some lost water. Over your entire body, that's a lot of capillaries. This is how slow this happens. Over your entire body, about 2 milliliters of fluid per minute escapes from all those capillaries. It's not that much. And there's the lymphatic system will capture that water and return it to the blood. So what are the factors that are going to affect these? There's some things that can happen that might change these forces and change the way things proceed. What we saw is just the general scheme of things under normal conditions. What happens when you vasodilate arterioles? When you vasodilate an arteriole, if this is right near the arteriole, more of the pressure in the arteriole is going to sneak right through, or of the arteries is going to sneak through into the capillary. If you vasodilate arterioles, this number is going to rise. It might be 40 millimeters of mercury instead of 35. Bigger amount of pressure, hydrostatic pressure, more water is going to filter. So when you vasodilate, capillary filtration goes up. Why? Net filtration pressure goes up. And if you have a lot of vasodilation happening, you're going to have maybe even some water accumulating in the tissue. That's called edema. Hypertension. If you raise the arterial blood pressure, you're also going to raise the capillary pressure. It'll be lower than arterial blood pressure, but it'll be higher than it was. What's going to happen? Increased net filtration pressure, increased filtration rate, more water being forced out of those capillaries. And again, people with hypertension tend to have edema, water accumulating in the tissues because so much is leaking out that the lymphatic system can't keep it all, can't capture it all. What about a hemorrhage? What happens to blood pressure when you have a hemorrhage? If blood volume goes down, blood pressure goes down. Now we have a drop in hydrostatic pressure. And so now the capillary filtration, the net filtration pressure is going to go down, and it may get so low that it'll actually be negative and it'll reverse. So if you have a hemorrhage, the first thing that happens is blood fluid starts to move into the vascular system from the interstitial space. You get a free transfusion in a sense. It's called autotransfusion. Some extra blood volume goes right back into the vascular system from the interstitial space to help replace some of that volume right away. Let's hope you've stopped the bleeding by now so that you can get things under control. You can actually, though, dehydrate your tissues if this is too profound, you have too bad of a hemorrhage, that can cause tissue injury to your organs because this autotransfusion will dehydrate the tissues substantially. How about dehydration? Now we have a drop in blood volume. If blood volume goes down, mean arterial pressure goes down. Hydrostatic pressure in the capillaries will also go down. Net filtration goes down. Filtration rate goes down. When you stretch vascular smooth muscle, it contracts. So that's something we discovered when we talked about myogenic autoregulation. So that will actually, I should have maybe put this somewhere else. If you have an increase in blood pressure, hypertension for example, that's going to cause an increase in capillary pressure, increase in the filtration rate, but then those arterioles are going to constrict a bit because they don't like that stretch. They fight against it. The myogenic autoregulation kicks in. We don't have as much increase in filtration as we would have had. What if the pressure in the veins goes up? Here's something I really want you to, I know we've been talking for a long time. If the pressure in the veins goes up on the venous end of things, where the blood's trying to get out from this capillary into the vein, if that pressure is higher, it's going to raise the pressure in the capillary because the blood can't get out until it sort of overcomes that venous pressure. That's going to cause a huge increase in capillary hydrostatic pressure and filtration rate. Way more than raising arterial or raising mean arterial pressure. Let me say that again. If blood backs up into an organ, maybe you're getting my gist now. If blood backs up into an organ and raises the venous pressure, that's going to cause a huge increase in hydrostatic pressure and capillary filtration in that organ, more so than if blood pressure had gone up. So when does this happen? What if you have left heart failure? Now the left ventricle can't pump away the blood that's coming back from the lungs. Blood backs up into the lung veins and then backs up into the capillaries. And now the filtration rate in those capillaries in the lungs goes way up. Water just pours out into the lungs, and that's where you get that congestion. Congestive heart failure. Water and edema is accumulating in the lungs, and it's going to eventually kill the person. How about changes in the plasma protein concentration? We've been talking about changes in hydrostatic pressure. What about changes in osmotic pressure, or we call it oncotic pressure? Is just a nickname that physiologists use instead of osmotic pressure. What if you have liver failure? Remember, it's the plasma proteins that are holding that water or drawing that water towards the capillary. If the liver can't produce those proteins, it's diseased. Now the plasma protein concentration is going to go down, osmotic pressure goes down, and now the net filtration pressure is higher. The hydrostatic pressure is the winner, and we have a lot of extra fluid escaping from the blood vessels. What about malnutrition? If someone doesn't have enough dietary amino acids for the liver to use to make the plasma proteins, it can't do it. Same thing happens. Lower oncotic or osmotic pressure in the capillaries, huge increase in filtration rate. Have you ever seen pictures of starving children in some part of the world where there's been a famine, or a refugee crisis. You see those huge distended bellies. Like, why? This baby is so emaciated. They have stick arms and legs, but what is up with the belly? It's fluid accumulating in the abdominal cavity that's come from capillary filtration. It's called ascites. Kidney disease. If your kidneys can't keep the plasma proteins in the blood, normally the kidneys can make urine by just controlling water and salts and small solutes and dealing with them. The plasma proteins stay in, but if the kidneys become diseased and the plasma proteins start escaping into the urine, no way can your liver keep up with that rate of protein loss. Plasma protein concentration goes down, osmotic pressure goes down, net filtration pressure goes up, and people with kidney disease start having edema problems, huge increases in capillary filtration. We have one last topic. It's circulatory shock. We've kind of talked about situations that sort of border on circulatory shock or may lead to circulatory shock, such as congestive heart failure or hemorrhage. Let's take a look at circulatory shock. If there's not sufficient blood flow being produced by the heart and the vascular system to meet the needs of the tissues, that's circulatory shock. This can lead to tissue injury. Your organs may start to die. Infarctions are death of tissues when they don't get enough blood flow, not enough oxygen coming in. So if someone has not enough blood flow, we need to remedy the situation right away to prevent this damage to tissues, because if the tissues die and the vessels in those tissues die, there's a good chance we're not going to be able to save the person and they're going to die. So this is very serious, very dire stuff, potentially end-of-life stuff. So you should know the symptoms because there's no time to lose. If someone is entering into circulatory shock, will have an unusually great rate and depth of breathing. They're not doing anything. Why are they breathing so hard? If you feel if you put your fingers, you palpate their pulse, what do you feel? A weak pulse, but a very high heart rate. Right? The baroreceptor reflex is trying like crazy to compensate for the drop in blood pressure, perhaps, and try to get something happening, but it's not enough. So the pulse is very weak. Not enough venous return to really get a good stroke volume. So wimpy little stroke volumes and poor pressure. Sympathetic nervous system comes online trying to correct things. Vasoconstriction, sweat starts coming out, all the things you'd expect from the sympathetic nervous system. Cyanosis is a blue color to the person's appearance. Their lips, for example, are under their fingernail beds. If they have dark skin, you can see that. They turn blue. They don't have enough oxygen in the blood. If they have light complexion, you'll notice pallor in their face. They'll be vasoconstricted like crazy, and that'll cause less blood flow to the skin, and it'll look different. They'll have way decreased urine output. If you're in a clinical setting, you'd probably be measuring their urine flow rate, collecting it right in a little vessel by the side of the bed or in a pan, measuring it. You see that in the ICU all the time, measuring urine flow. Too much, too little. Intense thirst. Confusion. At the end stages, there's not enough blood flow for the central nervous system. Confusion ensues, and eventually the person may enter coma and maybe even die. So very important to know the symptoms so you can intervene and do something about it. So I'm not going to go over this entire chart, but it illustrates some things. What happens if you lose a bunch of blood volume because of a bleed, a bad hemorrhage? You know, a drop in blood volume, drop in venous return, drop in stroke volume, drop in cardiac output, drop in mean arterial pressure, and therefore drop in flow. Pressure drives flow, so you're not going to have enough flow through the entire system. What's going to happen? Some compensatory things. We're going to have the baroreceptor reflex is going to come online and increase the heart rate, and increase vasoconstriction, and increase heart force as much as possible, and that's where that tachycardia is coming from. We're going to have overall sympathetic nervous system activation. It's going to activate the kidneys to release renin. Renin causes angiotensin II to be produced, and then the kidneys therefore will most of the vessels vasoconstrict and raise the blood pressure. Angiotensin II causes aldosterone release, which causes the kidneys to retain salt and water, increase blood volume, decrease urine output, and hopefully bring back some of the cardiac output. So hypothalamus baroreceptor reflex causes the hypothalamus to release ADH. ADH causes the kidneys to reabsorb more water, less urine production, more water retained in the body, and plus some intense thirst, and we're going to drink some water and hopefully recover our blood volume as needed and restore blood pressure and blood flow. So I guess I did go through most of that, but I want you to take a look at that. I want you to be able to feel comfortable with all the parts of this chart, all things that we've talked about, and make sure it makes sense to you and that you can remember those things that you see there. So let's just quickly mention a couple of types of circulatory shock. Ignore the second one. It wasn't supposed to be there yet. Hypovolemic shock means there's been a severe loss in blood volume, and therefore there's not enough blood coming back to the heart, not enough stroke volume, not enough cardiac output, and there's not enough blood flow. If you have a hemorrhage, too much blood loss, this could be life-threatening. Why? Because of hypovolemic shock. If you have severe vomiting or diarrhea, you're losing a ton of extra water out of the body that's not normally lost, can't keep up with that, and you could have hypovolemic shock. When people get cholera, they can die from hypovolemic shock because of diarrhea. Severe burns, you've lost the epidermis, you can no longer contain the water within the body, it just weeps out of the surface of your body. If you don't have enough clinical support, you may die from hypovolemic shock. All right, so all the things happen that we talked about in the previous slide. Vascular shock is another major category of causes of circulatory shock. It means that the blood volume is normal, but the blood vessels aren't constricting normally, and so we don't have enough blood flow, enough blood pressure, venous return, stroke volume, and flow. Here's an example, anaphylactic shock. If someone is very, very allergic to something, such as a food like maybe the peanut allergy, if someone has that very, very severely, and they eat the peanuts without knowing it, then they're going to have histamine coming into the blood, not just histamine in a local inflammation, histamine in the entire vascular system, which causes massive vasodilation. Histamine is a vasodilator, as you've known since the first week of school. Now we're just reminding you of that, but when it happens systemically, it'll cause a huge drop in peripheral resistance. There won't be enough resistance, and there won't be enough blood pressure. Right? Mean arterial pressure is proportional to resistance. Mean arterial pressure equals stroke volume times heart rate times resistance. Resistance goes way down, pressure goes way down. Neurogenic shock. If your sympathetic nervous system is compromised, right? So you can't control the vascular tone. You can't. The vasomotor center is not working. You can't control those vessels. They're going to dilate like crazy. There's going to be a massive drop in blood pressure. That's called neurogenic shock. There could be a drug on board that's suppressing the central nervous system. Can't get that to work. There could be an actual physical injury to the medulla oblongata, and you're getting neurogenic shock. Septic shock. If you have an infection in your body so bad that it's causing some toxins to be produced that's interfering with cardiovascular performance, causing vasodilation of blood vessels, massive inflammation, then you could have the same thing happening, massive drop in blood pressure, septic shock. Finally, cardiogenic shock. We talked about congestive heart failure. If it gets so bad that the heart can't even produce enough blood flow to meet the needs of the tissues at any time, now you could potentially enter into cardiogenic shock. And it could happen after a myocardial infarction, or it could be the late stage of congestive heart failure. And so we might not have enough blood delivery and enter into shock because the heart itself can't do its job. So that's the end of our story. I know that was a little bit of a long section, but these are really important topics. Please do make sure you understand autoregulation, capillary filtration and the things that affect it, and circulatory shock. And that'll wrap up our chapter 19. What a wonderful chapter on the cardiovascular system, a system that presents the medical community with an enormous burden as people age and find their health declining.